Everybody. Welcome to our CPPI seminar. I'm sorry I'm keeping my camera off. I'm holding a sick child, but here I am. And we are so happy to host Dr. Troy Trigstad here for us. He is a PharmD PhD MBA, and he is the executive director of CPSN USA, which is a clinically integrated network of more than 3,500 participating pharmacies. He received his PharmD and MBA degrees from Drake University and a PhD in pharmaceutical outcomes and policy from UNC. He has recently served on the board of directors for PQA, the Pharmacy Quality Alliance, and the APHA Foundation. He also proudly practiced in community pharmacies across the state. We are so lucky to have you, Dr. Trigstad, and we can't wait to hear all of the wonderful things you have to share with us today. So without further ado, I'll turn it over to you.
All right. Well, thank you for having me at this middle of the day hour on a Monday, and appreciate that folks are joining and they have an interest in this topic. The disclosure statement, I have no conflicts to disclose. We don't have any products. I certainly am employed by CPESN, and that's part of the conversation, but nothing else to disclose. All right. So the first quiz, why are community pharmacies struggling to survive? Evident that they are. And what is getting in the way of pharmacists being successful practitioner providers? Is it one, the clinical capabilities of the community pharmacist? Two, the setting of care is inopportune? Or three, the business model is a mismatch with the provider model? Or I should say the current business model is a mismatch. And so I often find myself in my day job trying to help folks understand um, the great untapped and underleveraged setting of care that is community pharmacy. Even though I spent my first 15 years of my career as sort of in pushing AmCare pharmacy and in practice in primary care, um, I've gotten deeper and deeper into community pharmacy. It's an incredible untapped potential. I came up with an analogy that I hope folks will appreciate. And it's the magic of surface area, right? So, how many of you online here knew that Minnesota has more shoreline than Florida, California, and Hawaii combined? What you're looking at there is I grew up in the summers in northern Minnesota. That's one county in Minnesota. Okay. Um, and you're just looking at a lot of lakes, but they have a lot of lake shore, right? That's surface area. So another example, humans have an average of 750 square feet of surface area in their lungs, so they can maximize membrane exposed for oxygen transfer. So 700, we all learned this, right? We've got this incredible structure right here in our torso, 750 square feet, and that's conservative low end estimate of surface area. Why? Because you're trying to create exposure to the environment, right? So when you go to Minnesota, there's all of this lakeshore. It's accessible. It's expensive, but much more affordable than shoreline most anywhere else in the country because it's a supply and demand, right? The lower population and higher availability of shoreline. And shoreline's important if you want to build a place to access the lake, right? So another example, an estimated 350 million COVID interventions occurred in community pharmacy in the 32 months across about 50,000 community pharmacy locations. So you had this really the gold standard example in the history of community pharmacy practice where, wow, this is the accessible population and the accessible healthcare providers to meet with that population, right? And now here we sit, 90% of all adult vaccinations now occur in a community pharmacy. So a need for that 700 square feet of surface area or all that shoreline, right, was there. You had healthcare providers that were very accessible. The old APHA saying that the entirety of the U.S. population is in a pharmacy once a week, and healthcare services were adopted in the form of vaccinations, and now not more than 90% of all adult vaccinations occur in a community pharmacy. It happened that fast. Why? Because you've got this surface area out there that can be the membrane with the healthcare system. Second question, why is it taking so long for pharmacies to adopt services as a business model? Because community pharmacists are lazy? I don't think so. Most non-community pharmacists wouldn't last an hour, maybe 10 minutes in a community pharmacy, right? There's little demand for affordable, accessible, and reliable healthcare services. don't think so. Community pharmacy is stuck in a business model because it hasn't been that doesn't work because it hasn't been able to bring value to the marketplace beyond lowest cost product or dispensing, and that is the case. So when I was first asked by my board of 72 primary care physicians when I was doing that in North Carolina to figure out how to incorporate community pharmacy into the medical neighborhood, I was very skeptical. I worked nights and weekends as a floater. Had practiced in over 120 community pharmacies across the state of North Carolina, the only state in which I'm licensed. Um, and I thought, oh, this could be on the hard pile to really do this kind of integration. And I sort of started to get into it, and I started to realize that pharmacy is pharmacy's problem, but not because of pharmacy. And what I mean by that is that we are sort of compelled to go to market together as one. In other words, we're the only healthcare provider that gets bundled across state lines into a monolithic offering, meaning there's 50 to 60,000 plus pharmacies out there. They do safe, accurate, and reliable dispensing. And we're gonna go to market with we can do it cheaper. We can bring this nationwide network to you cheaper than anybody else. And that's how Pharmacy Benefit Manager was formed. There really is no equivalent to the PBM anywhere else. There's kind of a PPO concept, but there's many parallels that fall down when you look at that with our healthcare brothers and sisters on the healthcare team. And so what we're really looking at is that we're always stuck at this standard of care, and there's no opportunity to innovate, provide new services. If you say, well, we should all increase the standard of care, well, that's fine. That means you're moving in lockstep 60,000 pharmacies at a time. Not easy to do because there's no market innovation, there's no disruption there, positive disruption, right? So, because community pharmacy, it didn't matter if you were a with capable of X or Y or Z in Indiana, you were sold along with the pharmacy that the only thing they did was dispense and counsel the over 90 in California or wherever else. Everybody was packaged the same and sold the same to employers and taxpayers. And so that opportunity to innovate never really occurred. And what happened was there was a lot of services, a lot of relationship-based care that was performed. Still is performed today, but less so because the margins are so low. But it was performed on the spread between buy and sell plus a dispensing fee. So even if I'm getting paid with my neighbor across the street, basically the same, even if we acquire at the same price, we get reimbursed on the product at the same price, have roughly the same dispensing fees, which is basically the case across the board. Chains buy cheaper than independents, but the equation's roughly the same across all pharmacies. If I wanted to get business, I might provide services. That's the innovation, so that folks come to me because I can provide those services and still make a dime underneath that product provision, under that retail model where I'm buying and selling things. So I would buy things and sell things and provide a service, even though it's a retail model, say like a Nordstrom would do. That doesn't work really well for those providing services because Nordstrom and all the other retailers that are out there are bundled and put out there as the same. So what happens? It's a race to the bottom on the experience because you can no longer afford to provide those services. So that opportunity to innovate's really been missing. And now we're finally starting to see a little bit of breakthrough on, oh, base pharmacy is I'm meeting the minimum regulatory requirements. I'm putting pills in bottles safely and accurately and cheaply, and I'm doing the DUR process. I'm counseling light, whatever's required. I'm letting people sign. I don't require counseling without any effort or intervention. And any other kind of legally mandated services. Maybe it's the prescription drug monitoring service, whatever it is. But everybody has to do it, right? And doing anything beyond that is not what's being sold in the marketplace to employers, taxpayers, policymakers. So we've historically been stuck in this box of base pharmacy. And then now we have, well, what if I do pharmacy plus? What if I do pharmacy plus plus? What if I do pharmacy plus plus plus? And we're starting to see the ability of the marketplace to start to look at community pharmacy as, oh, well, we have all of pharmacy that does this, and then we have some pharmacies that do this and that. That's how the medical profession works, right? There's general, and then there's also specialty, and Some folks do offer some services and not other services, and some are better than others at providing certain services. And you have a real sort of provider marketplace. A lot of the pharmacies I engage with every day are over in that right-hand side. They're capable of doing some incredible things. And I'll have a slide with data from health plans that they are the ones publishing data now, gray papers and other types of papers, saying, "Hey, we worked with pharmacies. We went beyond base pharmacy, and we're seeing it be good for patients, taxpayers, employers, and ourselves." I want to, as the trained health economist, I'm compelled to show you this slide. Now, it's a little bit outdated. This comes from 2017 data. If there's any academics on that would like to rerun this model and do it in a way that can be peer reviewed, please, I've been begging anybody that's willing to do this because it's a message that just needs to be told more and more and more folks understanding what's going on here. And that is the following. We're up over $4 trillion of healthcare spend a year. And if you don't know what $1 trillion is, it's a million millions. We struggle past six digits. That's why your Social Security number's got two dashes, by the way. But we're in 2017 we were at 3.6 million millions, 3.6 trillion. When you look at the post rebate adjusted gross, because we're approaching 850 billion or so, right? So that's 8,500 million. As we approach that number, I'm sorry, 8,500 million. That's 850,000 million. I got that wrong. Of pre-rebate costs, right? So you take the 3.6 that we spend on healthcare and you go, okay, pre-rebate cost is about 850. Now it was about 550 then. Post rebate costs, because 30, 40, 50% go back out in rebates. They go out to 340B entities. They go out to the Medicaid drug rebate program. They go out to employers with pharmaceutical rebates through the widely known rebate system. After you take care of account for all those rebates, it actually costs less than 10% of the entire nation's healthcare spend. So would it be about 400 to 450 billion dollars now? All right. So less than 10%. Now, you net out the VA, you net out Part B, right? In office, you net out infusions, you net all that out. Now you're down to 6.7% or 242 billion. Then you get to community pharmacy, so you net out mail order, sort of specialty pharmacy that's Part D, and you're down to 4.3%. So 4.3% is all of the pharmacy and the drugs that come through the pharmacy. When you net out the drugs, what do I mean by that? What I mean by that is drug in, drug out. So whatever I paid for the drug, if I paid $100 for the drug, and I got reimbursed $102, if I take out that 100, which is not me, it doesn't have anything to do with me and my operation, that's just product in and product out. Because if you use a benchmark of about 20%, what would be called gross profit, that's just I paid for something retail, I sold it retail, the difference being the 20%. It's only 156 billion goes down to 31.2. So that's about 20% of the 156 billion. So we're down to 0.86%. What does this mean? When you're looking at this here, what it means is the cost to the system to operate community pharmacies, 50,000 or more across the country, to operate them. So that's everything. That's the lights, the building, the pharmacist's salary, the other staff salary, the labels, the bottles, the bags, the software system, everything but product in, product out. So that's what it costs to operate them, less than a percent of the healthcare system. And we're about 6% a year growth or inflation if you look past 2 to 3 decades. Meaning that it would take 2 months. If you got rid of every pharmacy in the country, and the cost to operate them, it would take 2 months to just make that up in general healthcare inflation. And that doesn't even speak to people not being able to get their meds and whatever costs associated with that. So we have this incredible resource that does not cost the system hardly anything. Primary care's another one that's about 5% or less. So primary care and pharmacies to operate are less than 6% of the entire system's spend. Let that sink in because it's about 90% of the care. All right. So 2 to 8 billion in services opportunities would transition pharmacies and keep them open in the short run. So we have a lot of pharmacies closing. If there were 2 to 8 billion, and 2 to 8 billion is a small number, again, up against 4 trillion. 4 trillion, 4 million millions, 2 to 8 billion, 2 to 8 thousand millions. It's itty bitty. All right. 100 million is only 0.003% of the total healthcare bill. Again, when you get to big numbers, our brains can't comprehend them very well. So 2 to 8 billion in services would have kept all these pharmacies open. All right. A complete swap where you say, look, we'll give up the retailing entirely, which isn't going to happen in the short run. But if you gave up retailing entirety and just said, look, I don't buy or sell drugs anymore. I just rely on services, 35 billion or 35,000 million would do the trick. Again, a small amount. It would be right at about or a little bit less than 1% of the entire healthcare spend. All right. So I wince a little bit because there was some CBO scoring that came and said, oh, if we give pharmacist provider status, it'll cost between 30 and 40 billion. And a lot of the association folks were like, ooh, they winced. That sounds like a big number. No, it's the perfect number. That's exactly what we should be asking for. 1%. If you give us 1% for services, we don't even need to charge you for the drugs. Okay. So, what is the big problem? The big problem is misalignment, right? So, I save money building bridges, providing care, but I get paid to build tunnels. I'm a retailer. And it's kind of crazy in 2025 that we're actually still retailing. And so now the equation for community pharmacies is hopefully and necessarily more complex. Maybe it'll become less complex, but right now it's four buckets. It certainly is for the CPSN pharmacies, and we hope more and more CPSN pharmacies really have a four-part equation. I bought a drug. I sold it for a price. There was a dispensing fee, which is like 10 cents now for Medicare this next cycle, on average, generally. Not breaking any rules here. And then there's a healthcare service, and then there's a performance. The combination of those buckets has to lead to a net profit, right, to be sustainable, even for not-for-profits, incidentally, right? So that equation has to work. If I'm below cost on yellow, I have to be able to be above margin on healthcare service or performance. If my dispensing fee is 10 cents that I get, but my cost to dispense is 12 bucks, I got to make up $11.90 on service or performance. Or I need to figure out how to buy for $12 less, right? I have to be able to come up with a positive number on that right-hand side. Interestingly enough, just this morning, so yes, this slide was created like 20 minutes ago. Cigna, which is Evernorth Express Scripts, largest PBM, and the one that serves the most external clients. They're important, I think, in my mind as a harbinger because Caremark mostly serves itself, not all. They're a little bit more like Express Scripts in that way. And then Optum Rx is definitely a little bit more internal, so serving their own plans. Cigna's a very, very, very small part of Evernorth as far as revenue and it's very much they're going out to clients. And so they're to me a good harbinger for or a good sort of litmus test or trying to figure out where is the PBM model going as a offering to the marketplace because they very much rely on external clients for their business model. And they just came out this morning with their push to say, hey, we're doing this differently. We're going to do rebate transparency. There effectively won't be any rebates behind the scenes for commercial, but they're saying we're going to move to a cost plus model. So sort of net out that buy and sell the product. A proper dispensing fee, perhaps, we'll see. A service fee, and other opportunities, and then performance incentives, which aren't stated, but that's where it always will end up, right? So once the fee for service model gets big enough in cost, to the system, 10 billion, 20, 30. Again, our target's 35 billion to save community pharmacy for forevermore. There's going to be, wait, I want to pay less if I get less, and I want to pay more if I get more back. And so that's coming if you have the first four bullets. So again, watch this space. From a CPSM perspective, what are we? We're a clinically integrated network of pharmacies. We do have a grocery chain and some smaller chains, but generally speaking, about two-thirds of our participants are sole location, mom and pop owners, and most of the other third are multiple locations. So they'll be from 2 to 5 or 2 to 8 locations. So these are your kind of small business pharmacy world for the most part. It was in partnership with the 72 docs that were operating a CIN in North Carolina saying, oh, great, well, you've got this opportunity, but you have to be, if you're going to be a clinically integrated network, you need to be governed by the pharmacy. So we partnered with NCPA, it pushed out, now it's its own organization. And so it's a self-governed. The pharmacies in the network govern it. I answer to a board of 33 pharmacy owners that come from all of the networks, the more than 40 pharmacies that are affiliated. That's actually an old number. We have just reached our 400th program. Now we consider programs to be contracts the way we roll them out. So some of these are repeats, but a lot of experience over the last 7 or 8 years, deep experience in how do you contract for a service, how do you adjudicate that service, how do you do lots and lots of things, and the majority of them have been Medicaid, and the majority of them have been with the health plan. We do have some PBM, we do have Medicare and light commercial. Um, but we administer payment in roughly two-thirds of the programs, and we generate a lot of learning. So I'm sort of saying this just from the perspective that I'm coming from and a lot of experience with what's coming down the pike and what's going on. So our mission is the sustainability of community-based pharmacies through patient-centered enhanced services that transcend the conventional outpatient pharmacy contract obligations. It's our belief that if there isn't a focus on patient-centered enhanced services that transcend the typical contract for product reimbursement, that these pharmacies really have no chance of survival. And if you believe that they need to be out there and that they're good for their communities, then you want them to survive. I had the opportunity to talk to AMCP, right? So this would be the group of folks that are in managed care pharmacies or the PBM pharmacists. Gosh, 3 years ago now, it seems like yesterday. And the main message to them was, you're living over here on the left-hand side, and in the grand scheme of things, this is a very low value expression. Um, we are having conversations and spending a lot of money and people's time and effort, both on the PBM side, the sales side, but also on the pharmacy side, managing all of this and this game of retailing and the drug cost police, right? And remember what I just say, less than 10% of the healthcare system's costs are for drugs post rebate. I like to point out that we spend less on drugs as a proportion of the total cost of care for most OECD countries. So there's the developed countries across the world. Yeah, we spend a lot on drugs and particularly brand name drugs. We actually spend a lot less on generic drugs than most countries. All the way through the process, but we spend a lot on brand name drugs, spend a lot of attention around that. But still, all drugs total, as a proportion of total healthcare costs, it's less than most countries that are developed. We spend a lot of money on everything in the US. And we spend, in particular, a lot of money on end of life care and of hospital care and sick care, right? And so here we are over here in pharmacy world, the pharmacy and primary care are the two greatest preventive tools that we have in our system, and they're a nickel in the bucket of a dollar for the healthcare system. And so we spend all this time and energy on drug cost police stuff, AWP, WAC, MAC, DUR, ASP, SMAC, relates. I told Joe Moose once, I was like, how much time in the week do you spend looking at your purchase, looking at your sale, picking which drugs, this, that, and it's just like it's crazy. If they spent that much time and energy on caring for patients, they would crush it. It's just a bunch of wasted energy from where I sit. And then the two sort of services are CMRs and PDC. Don't get me started. I'll have a slide on this a little bit later. So I said to them, look, you're hanging out over here in this world. In the grand scheme, to the larger part of the healthcare system, it's a very low value expression. You're like the drug cost police essentially for the brand name drugs, but there's a lot of mystery in there and people really don't know if they're getting a good deal. And then on the generics, you're just grinding it down to nothing, but you save a little bit on a generic on the grand scheme of things, it's nickels, right? So, you're not providing a lot of value to the healthcare system, right? Here's where everybody else lives. Health risk assessments, A1Cs, blood pressures, readmission rates, remote monitoring, ACT, CAD screenings, LDL, care management, primary. This is the 90% of the healthcare dollar over here, and broad groups of providers, broad group of measures, incentives, and penalties, right? So I think PBMs are going to kind of come to a crossroads where are we going to continue to just be the drug cost police? Because transparency is coming. And is it going to be more of a transactional kind of a space, or are they going to get into more high value expression? I would say the update 3 years later after presenting this is I think they're starting to see that they need to expose themselves and play on the right-hand side, but I think they're having a really hard time selling it to purchasers, particularly on the commercial side, because they've typecast themselves, right? Like they're that actor, actress that as soon as you see them in the playbill or in the promo or the trailer, you're like, oh, I know exactly what that character is going to be. And so they're having a hard time, I think, coming to the marketplace with something different, right? So one, they've always been the drug cost police. They deal with the pharmacy benefits person as the broker. Well, they make money on drugs being sold. They don't make money on services, right? And they have a certain mindset and skill set. So they're not even part of the conversation with the rest of the benefit. And then they're still packaging things nationwide. That's not going to work either, right? The rest of the healthcare system and the health plans tick on state level or regional level, right? So it'll be interesting to see what happens in the PBM space. So for us, just to give you a sense of a herd of unicorns makes unicorns real, is that every different kind of service. So of those 400 programs, except for the repeat ones, every one of them have been different, for good or for bad. We've learned a lot, but there's not a lot of standardization around them. I think the market will work towards that, but we've done everything, and the pharmacies are willing to do all of this. And I think they surprise themselves with how good they can be at it and how much they enjoy it. Certainly for the subset of pharmacies that have sort of favorably selected into the network, but gap closures, screenings, pharmacy care management, test treat, telehealth, E&M, CPT, RPM, encounters. Um, what's becoming really popular? Maternity care in a pharmacy. Okay. Very popular, working in the Northeast, going to spread. All right. So, setting of care, right? Surface area, accessible. Both the greatest thing about the pharmacy and also its Achilles heel from a workflow flow perspective. We'll get to that, right? But surface area, accessible, affordable, cost of engagement, very, very low. Why? Because people are already picking up their meds, right? When I worked in primary care would love to have that. In fact, that's kind of what they do with direct primary care and dispense out of a Pyxis, right? Because folks are coming in already and you can catch them for other things that they need. It's the secret weapon of community pharmacy is probably the superior side of care for primary care light, frankly. All right. Measures. We've done HEDIS. We passed HEDIS data along for HEDIS measures, stars, withholds, again, blood pressure, all of this. We've done single-sided risk on shared savings, hospital rates, ED rates, all those types of things. Fee for service, fees at risk, location level incentives, network level incentives, and shared savings and rewards. This is the time period for community pharmacy that medicine went through sort of the turn of the century through up through ACA, and then it got implemented through CMMI. We're going through that finally now as pharmacy from our perspective. And if you don't believe me, just go to the cpsn.com, click on success stories. You can see, I think we have 250 plus posted there. They're real. Common barriers, workflow friction. By far the biggest impediment, longest to overcome if the dollars and cents may add up. Because workflow friction is expensive. Administrative resource consumption, a sister to workflow friction, right? So you've got this generalized administrative cost. Just go ask why a lot of primary care providers are moving to direct primary care. 40 to 60% of the cost of running that practice is administration, right? So between workflow friction, administrative resource consumption, and then we get, because we're so privileged over in community pharmacy, we get the third killer. It's the triumvirate of success killers, which is congrats, you have 6 cases this year to work, right? So we do, hey, love that we've got the ability to counsel on hormonal oral contraceptives and bill for it. That's great. Let's keep doing that. Let's show that we can do it and do it well, and it's accessible in rural and underserved communities for sure. Can you build an entire practice around that? No, you can't, right? You can kind of find niches and maybe you live next to a college campus, whatever it is, right? But it's not a practice. You have to have enough scale there. And then CMRs, give me a break, right? Lack of service outcomes dyads. Outcomes can come in many forms. Lower blood pressure, happier patients, patients that seek demand services. I would argue that pharmacy, as much as we've pushed services for a long, long time, we've not tied a particular service to a particular outcome and created a dyad out of them. But now that's happening. And then lack of clinical training and know-how. In my own opinion, again, I was responsible way back in 2006 for putting 110 different pharmacists embedded with primary care and behavioral health specialists and 1,200 care managers across the state of North Carolina. Very much believe in all those people and those settings of care. But also practice nights and weekends for 17 years as a floater, with a little bit of update on JNC and some other stuff, and a little bit of practice. I could be a clinical pharmacist too. The vast majority of drug therapy problems out there are not complex problems. They're very simple problems, right? And it's really more about learning the workflow and sort of the patient encounter stuff. It's not the clinical knowledge. That to me, that's a non-thing. But we got this crazy system right now, right? Part D is the MTM. I understand why and how it came to be, but it was the single dumbest design program of all time. Unfunded mandate, so there's no funding for it. You just have to build this in as an administrative cost for your Part D plan. And it has all the features that aren't scalable or sustainable. So workflow friction. I'm going to jump into different systems for different opportunities. Stupid. Stupid, stupid, stupid. We don't make physicians jump into the Cigna EMR for Cigna patients, and then the next patient's a Blue Cross patient. We make them jump into the Blue Cross patient. And then we actually we get 6 patients assigned to us for that day, or we get 20 patients assigned to us, and maybe some of them don't show up or whatever. No, I have a practice. I identify a problem, I can address that problem, I bill for that problem, and I do it in my own native system of record. That's what a practice looks like. Again, this administrative resource consumption, it really needs to be 10% administration, 90% care delivery. Again, lack of scale, 6 to 20 patients a year does not make a feasible business model. So one of the things that annoys me about some of our teammates in pharmacy world, regardless of where they come from, but including academia, is they look down their noses at community pharmacy and say, well, why aren't you doing this? Or why don't you do a good job? Why don't you do a good job and build a business model around 6 to 10 cases a year? I mean, it's stupid on its face, right? And then lack of service diet outcomes. I was in a room of over 100 pharmacy owners just last week, and I asked them, um, what is the service outcome dyad associated with a CMR? Where does it say what we're supposed to be accomplishing? Is it that we're just finding drug therapy problems? Is that an outcome? I find problems, right? Have you seen that commercial, right, where the dentist finds the largest cavity he's ever seen. The person's in the chair. And he says, "Well, time for lunch." And the patient says, "Aren't you going to fix it?" He says, "Oh, no, we don't fix cavities. We just find them." That's what we do with CMRs, right? There's no like closure kind of construct, and there's no outcome associated with it that ever gets measured or anything closely associated with it, right? It's just stupid. So if we're going to achieve scale, we have to have this lower administrative friction. I keep saying that over and over and over again because it takes all of us to solve this problem. And our experience on the CPSN side through these hundreds of programs is that the first program was a killer, right? I mean, I remember getting a contract. This particular, it was a CHF service across 5 states with a Medicare Advantage plan, and they didn't have any contract for services or any construct of a contract that would be used for pharmacies. That tells you a little something too. Pharmacies don't have a relationship with health plans. They don't have a data relationship. They don't have a contract relationship. It all goes through the PBM. I mean, just let that sink in, right? So we get this contract, and it was basically a software contract. They said, this is the closest thing we have and here you go, redline it. And it was like a bloodbath, right? And so that plus the administration of it and trying to get it going, very, very expensive. So the proportion of the dollars that were spent by the payer, and we don't even take a penny on the CPSN side, that's our policy. We generate all of our revenue from homeowners association dues or participation fees from the pharmacies. Don't take anything out of the middle, right? So between us charging those fees from the pharmacy to administer these programs and all the money they spent on their side that they could have otherwise spent on providers, and then all of the effort and labor and stuff and systems on the pharmacy side, all of these initial programs are at the end of the day, they're, net negative until you can get to scale, till you can reduce administrative friction, till lawyers have developed a compendia of contracts that can be reused over and over again with pharmacy networks. And that's starting to happen. We're starting to see it turn to the green in the marketplace. And certainly for our pharmacies, it's getting closer and closer and closer. I would say we've got 5 or 6 really key contracts now that are in the green for the pharmacies, right? And the purchasers. So when you look at the cost of care delivery, it's basically the same over time, right? It doesn't change a lot over time. It's the cost of the documentation and the cost of the transaction, right? So if you look at the reimbursement in gray, the problem we've had heretofore with pharmacy, again, lack of scale, workflow friction, administration, is that you're getting paid about into the middle of that orange, but the total cost when you do the care delivery, the administration, the cost of transaction is more than the amount paid by, you're losing money on these things, right? So it doesn't make sense to do them. They're not sustainable, right? And not only are they not sustainable, you're losing money. You're making the problem worse with a lot of these programs, right? So if we reduce the cost of documentation, reduce the cost of transaction to a point where, all right, we've got this cost of transaction administration, you can actually develop a margin, right? Even if the cost of the delivery, the care delivery is the same. So, example of the most successful services-based program in the history of community pharmacy is quite obvious, right? It was COVID. Totally sustainable. Magic number. It was about $10 billion that was spent on immunization administration fees. What does that mean? That means those were services-based revenue. In this example, the government owned the vaccines. So what does that mean? Pharmacies were not buying or selling anything. They were getting a $40 fee for the service. And it worked really, really well. From an adoption perspective, scalable, low workflow friction, right? Low administrative resource consumption, high service outcome dyad, number of patients immunized, number of patients tested, straightforward, right? So there were over 350 million clinical interventions across over 150 million people. Why were you able to get pharmacies to do it, and why did it help the balance sheet and the bottom line of the pharmacies? Low friction, low administrative resource consumption, and good for the purchasers, the government, employers, taxpayers, because there was a high service outcome dyad and it was tight and you could measure it. So what's working in our neck of the woods these days? The technology standards and capabilities are now starting to evolve. We're past kind of the pilot phase and we're on the shoulder of the scaling phase. If you're not in and around community pharmacy, it's the best of times, it's the worst of times. In the sense that hopefully all these things turn quick enough before the redwood forest is cut down and there's not enough lakeshore to provide that interface with the healthcare system for all those folks, especially out in rural and underserved communities. But now we're getting to templates, semi-automated, automated documentation, able to participate in the same venues of collection and submission, A1C, HEDIS. That wasn't the case even 5 years ago, right? We're submitting A1Cs, the pharmacies are submitting blood pressures, A1Cs, health risk assessments, these types of things directly to the health plan. And the fastest payer program right now is medical billing support. 17 different states where pharmacists are billing CPT coding, and a lot of inroads on how do we scale credentialing, delegated credentialing, how are the systems scheduling, templating, and providing quick paths to the medical billing, to the X12 transactions. A lot of that's going on, and if you're not in and around community pharmacy, you may not be seeing it, but it's coming and it's starting to scale. So, final quiz question. Will pharmacies ever prosper as a services-based economic and policy model? No, there are too many supply chain interests. Well, as things go, pharmacy is pharmacy's problem. So once payers want it, once the public wants it, once the policies are in place, there's still a lot of people that make money on the buying and selling of drugs as it goes through the laundromats, through the system, right? All the way up and down the line, including some of the pharmacies and pharmacy interests out there, right? So it kind of holds us back. No, there won't be enough human capital. That worries me a lot. I'm hearing it's difficult for even the best community pharmacy residencies now to recruit and get folks in. We've got to turn that attitude. I would say if you're in New Mexico right now, probably Washington, maybe Texas, probably soon to be Pennsylvania. If you're in those states and you're an AmCare pharmacist, great, love you, but setting up a practice in a pharmacy is going to be very, very appealing soon, right? If you can bill as an individual practitioner with the setting of care as a pharmacy, low cost to capture patient. I've got the ability to really provide care for that patient, right? I've got the ability to bill. Um, but we've got to get people excited about that setting of care. Or yes, patient consumer voters will demand it as systems become more and more incapable of providing basic, accessible, and affordable care delivery. Again, as the economist, I see the economist in me sees everything through the lens of economics, and that usually explains everything in the world, right? So I always say that science explains how the world works the way it does, but economics explains why the world works the way it does, right? And so one is a compelling answer, two is a compelling answer. Three is ultimately the my hope and my belief is that the system is so crappy and it's getting crappier and more expensive every day that folks have got a taste of what pharmacy care looks like. And again, 90% of adult vaccinations happen in a community pharmacy now for a reason, right? People go, oh yeah, of course that's where I go. 10 years ago, it would have been, what? I'm gonna go get a vaccine ordered and administered in a pharmacy. That oh wait, yeah, we might do that with flu now, those kinds of things, right? Now it's just ubiquitous. So don't sleep on community pharmacy. I am bullish if we can get through what is a disastrous and imploding current business and reimbursement model. Um, so the technology standards, again, now they're evolving, right? So documentation of a plan of care, this is ubiquitous within community pharmacy. Yes, the systems are not very great right now at reducing clicks and reader energy and typing energy and all those things. I think AI is going to very much solve a lot of that problem. This idea of not having a plan of care. Look, if you're going to be billing for services, just like PBM's audit for dispensing, there's all sorts of folks willing to audit in a shared savings model. Your pharmacy, just like they audit everybody else in the healthcare system. So you have to have a plan of care. That's what the JCPP plan of care. We have to if we're gonna pretend if we're gonna want to be adults at the adult table billing for services, we need to act like it, right? But we just need to make it efficient, and we need to make it so it's not the third year therapeutics in school epistles, totally unnecessary and not helpful. There should be a whole class, by the way, VCU and others, the Twitterizing of patient plans of care. They do not have to be long. They should be short and effective. Okay. Service opportunity alerting in workflow. Again, if your cost of engagement with a patient's really low and you're able to, oh, they're here for this, here are the 5 gaps in care, super powerful, right? Because patients cycle through pharmacies much quicker than even primary care and certainly specialty care, right? Across the populations. There's a competition going on right now between various entities and standard entities to who's going to be the main entity in the transaction. That's a good thing. That means there's going to be a sort of a race to try to make it easier to bill and easier to document. Templated charting, again, I think not only for template's sake, but AI is going to really help with this. It's already starting to help. Epic, the EMR, released their first physician tools that will translate over. APIs, so if you don't know what an API is, don't worry about it, but the fluidity and the liquidity of information between systems is really starting to move along now. And then just the business intelligence, revenue cycle management, these times of paraprofessionals rapidly accelerating. We have pharmacy technicians now trained as patient navigators, community health workers. We'll probably start training them as phlebotomists, getting into on-site clinical trials, decentralized trials. A lot going on out there that will start to scale. So I'm selling community pharmacy because I'm a believer in it now, but it's still untapped potential. But the health plans are really starting to take note. So everything up here on this screen, I'll just leave it up a little bit. I have a primary care physician who's the chair, vice chair every other year because of our history with primary care as an organization. And, he blushes at these results. These are not, we didn't come up with this. This is the health plans with their own data, with their outcomes folks coming up with this data. So do we want more peer-reviewed stuff on this? Yes, but these are the client's customers and they're happy, and these are the numbers that they're finding. When you get a pharmacy to do the services, at least in our world, they tend to do a really good job. The hard part for us now is we've gotten through the 3,500 pharmacies that are more willing and able, and now we're getting to the more the middle of the bell curve. So sort of massive practice transformation, lifelong learning efforts if you're in a school of pharmacy as this comes along. Really big opportunities to engage alumni and others. All right, so in summary, and then I would love to entertain questions. Hopefully, I'm on time. I have a bad reputation. 12:47, but a rightful reputation. If we want pharmacies and pharmacists and pharmacies to participate in sustainable services-based business models, they need to be paid or credited in a closed system, however you want to look at that, with at least 10 to 20 patient encounters per day with administration and adjudication less than 15%. If we can accomplish that, there will be a growing and thriving community pharmacy-based uh, practices across the country, and we will be able to keep many tens of thousands of pharmacies open. Again, we need about 4 to 8 billion for this to really stick as a practice model. If it sticks, it'll be bigger in some pharmacies, smaller in others, but still sustainable and sticky. And there will be pharmacies still that don't do much of this, and maybe they go the way of the dodo bird. I don't know, but it's not that much money. Okay, so just quick math. 8 billion over 60K pharmacies is about 133K per year. That's enough for an FTE roughly to be minimally sustainable. By the way, FTEs are far cheaper in community pharmacy than they are in health systems. One of the things I learned working with docs and health systems is just the overhead, the support is just a lot more expensive in those kinds of big systems, right? So you can spend 133, K as a taxpayer policy person efficiently in community pharmacy as well, right? And that we have to be comfortable with the idea that it's distributed unevenly and it's based on the business model or posture, right? So are you pharmacy plus? Are you pharmacy plus plus? There's also going to be all sorts of varieties of pharmacy plus plus plus, right? And we have to be okay with that. We're not taking all the pharmacies to market with the same thing because the same thing reduces to what? The standard of care, because then there's no reimbursement model for anything beyond the standard of care. The arrows pointing up slide. So it really is critical that we have networks of certain types of capabilities and providers, right? Just like medicine and everybody else. 40 billion, 35 would be sufficient. 40 billion, I think by the time we get there over the course of the next 5 to 10 years is going to be necessary. It does ensure pharmacist and pharmacy sustainability. If you're a school of pharmacy, if you're pro-pharmacist profession, we should all be cheering forward, regardless of what setting of care we operate in, for 40 billion to ensure pharmacist and pharmacy sustainability. It's a very small number against 4 trillion, right? 4 trillion, 4 million millions, 40 billion, 40,000 million, 40,000 million versus 4 million million. It's a small number in the healthcare economic terms. And it's a very small number now in proportion to the 340B program. Just let that sink in. You could pay for pharmacists 3, 4 times over now for the amount of 340B net that's going on out there, okay? The dispensing business model will need to be less and less pharmacists, and the service model will be more and more. I think the biggest lie ever told was, hey, let's do tech, check, tech, or tech ratio, or let's let machines fill things because it's going to free up time for the pharmacist to provide services. I'm for all of those things. But the biggest lie told was that we're going to have the time to do those services because we're not going to have the time to do those services. There's no business model behind it. It is the business model, stupid, right? And so, yeah, we want to free up time when there's a reimbursable or billable time, as a physician would put it, when you free it up for me. We need to do both of those things simultaneously, right? All right. So I've said my piece. Open for questions. Hopefully it was interesting and helpful. And